Thank you, Lakmal. Thank you, madam. Good morning. So it's my pleasure to be here and do this presentation. Today my presentation is on prescribing in the elderly. So I think it's a very relevant topic to medical practitioners like us who does the practice in Sri Lanka, because Sri Lanka is one of the fastest aging populations in Southeast Asia. So nearly 11 to 12% of our population is more than 60 years of age. So we should know what are the differences when it comes to the prescription of elderly people. We know that in our ward setup and as well as in our outpatient clinics, 30 to 40% of patients are elderly. So it is a significant challenge to a clinician to do a rational prescription for a elderly patient. Having said that, so in my presentation, I'm going to touch upon these areas. What is rational prescribing? Prescribing consideration in older adults, polypharmacy, stop and start criteria, and stepwise approach for prescribing. As you all know, as clinicians, the prescription, writing prescription is the main tool we use to cure patients, relieve symptoms, and improve future problems. All these things we do. All these things we do by using this tool. This is a major tool we use, and also it's a complex intellectual task. We have to select the most appropriate thing out of thousands options available, as well as we have to consider the infinite variations of patients that we encounter. By considering all these factors, we do a complex intellectual task when it comes to a rational prescription. So when we are doing an appropriate and rational prescribing, so we have to consider these, we have to attempt these four things. We have to maximize the clinical effectiveness, and we have to minimize the harms which will happen to the patient, and avoid wasting scarce healthcare resources, especially a place like Sri Lanka where we have limited resources. So that also we have to consider when we are doing a rational and appropriate prescription, not only for elderly, even other patients also. And we have to respect always the patient's choice. That is not all the guideline, all the protocol. So patient's choice also should be encountered. That is very that's one of the lacking part in our practice. So the process of rational prescribing involves many steps. First of all, we have to make a diagnosis or near diagnosis. It can be a definite diagnosis or it can be primary and secondary diagnosis. On this background only, we start the process of making the prescription. So next, we have to consider the treatment options. As I told, that now in this evidence-based medicine, everything is there. So we have to get the maximum beneficial therapy out of these treatment options. Then we have to do the rational prescription from those background knowledge, and it is influenced by the pharmacokinetics, the drug factors like pharmacokinetics, pharmacodynamics, the evidence base, as well as cost effectiveness. Not only that, there are patient factors also where we touch upon the elderly people, the age and sex, age and gender of the patients, and interacting diseases. There can be interacting diseases. When we are writing a prescription, we have to consider that, and interactive drugs. Also there. So when we are doing a new drug, when we are prescribing a new drug, that we have to consider. And genetics also, there with the genetical variations are there, especially when we are taking guidelines and things from the from other kind of countries like America, UK, and Australia, like that. We have to consider our genetics and their genetics, especially when it comes to prescribing in elderly. And not only that, prescriber factors are also there, because we have some familiar drugs. We know by prescribing those familiar drugs, we know the outcomes, because as the prescriber, as the clinician, we take the responsibility of the effectiveness of the treatment. So to take the responsibility, we are also having some sort of some sort of bias to the familiar drugs. That also come into the prescribing process. And also, we have to make the patient counseling, especially in geriatric population, geriatric patients. When you are doing a new drug, we have to, when we are doing a prescription, we have to tell the patient, these are the drugs, this is how we are going to do, these are the adverse effects and side effects which can happen. And so you have to come back to me if something happened which is new to you. So we have to make the patient counseling and monitoring, of course, there should be there, especially elderly people in the reviewing visits. We have to do the monitoring. This is the process of rational prescribing. So we will see, we will go through one by one. So goals of therapy, as I told you, the curing the disease, relieving the symptoms without affecting the underlying condition. We might not be able to cure the disease, but we have to relieve the symptoms. When we are relieving the symptoms, we should be aware that we should not mask the underlying problem. So as we are in the process of diagnosing. And combining the both of above, like when we are treating rheumatoid arthritis, we do prescriptions to cure the disease as well as relieve the symptoms. And long-term prevention, like we are giving statins for the hypercholesterolemia to prevent future MIs, like that. And replacing deficiencies like iron deficiency and B12 and things, those are also one of the goals. And addressing lifestyle wishes of patients and therapeutic trials to aid diagnosis, like giving edropodium to diagnose myasthenia, like that. So these are the ways, these are the goals of therapy. So having said that, the aging and frailty should come to the picture when it comes to the prescribing in elderly. We all know the physiological aging is the time-related loss of functional units within an organ system. It's a single organ system, the time-related loss of functional units like nephron in kidneys, alveoli in lungs, like that. But the frailty is little complex sort of phenomena that you lose the gradual loss of functional, biological and physiological inbuilt reserve in multiple body systems. So the frailty is a concept, is a thing that is mainly affect that mainly affect the aging population, and that will have they will have vulnerability to major problems when it comes to frailty. So after having these explanations, so I will move to the case scenario, which is a very common thing we are encountering in our outpatient clinics. Mr. I.M., who is an 80-year-old retired school principal who lives with family, and he has past history of hypertension, chronic stable angina, osteoarthritis of right knee joint, benign prostate hyperplasia. About 3 years ago, he suffered from poor sleep, disorientation, and some auditory hallucinations. For that, he took treatment from a psychiatrist. And then he was diagnosed with iron deficiency anemia 1 year ago. He has chronic constipation, for which he frequently meets his GP. He was very independent of both basic and instrumental activities of daily living, and he's a sociable gentleman. He lives with wife and a younger son who is a bank officer. He's a well-off person. So their 2 daughters are living abroad, and they support parents financially. So his current medications are as follows. This is when he comes to the clinic. These are the medications he was on. Aspirin 75, nifedipine 20 mg BD, tamsulosin 0.4 mg nocte. All these drugs are to treat and improve his problems, which I discussed in the history. Atorvastatin 20 mg nocte, risperidone 2 mg BD, tamiflu 2.5 mg nocte, ferrous sulfate 200 mg BD, diltiazem 30 mg TDS, and syrup lactulose 10 mg BD for his constipation. His recent test results showed the creatinine was 0.9, which is normal, sodium potassium normal, and hemoglobin was 12.8. So considering his prescription has background history, what is the common geriatric syndrome he suffers? So when it comes to prescribing elderly, we have to discuss, if we are not discussing this problem, it is a deficiency of my presentation. So we have to discuss one of the geriatric giants that is called polypharmacy. So this gentleman is suffering from this problem, polypharmacy. He is taking 5 or more than 5 drugs, which is a common problem in our elderly population. So the case scenario doesn't stop there. So it goes, his daughter who lives in UK sending him fish oil and glucosamine sulfate tablets. So that is very common. The next generation is living abroad. They send their all these over-the-counter medications to their parents to make them stronger till they come and see them. So then fish oil 1 capsule a day, glucosamine sulfate 1 tablet every other day. This retired principal is very intelligent. He takes glucosamine sulfate every other day, not daily. So that is what is called brown bag review in prescribing in elderly. We have to review not only the prescription, the other drugs also. Usually our elderly people, they take Ayurvedic medicine, the Hamuduro's medicine, everything including the clinic medicine. So that is what is called brown bag review. So when I reviewed it, these are the other 2 medications he was on. So what are the inappropriate prescriptions that this gentleman encounters? So duplication, I think you have noticed that he has taken duplication of drug classes. 2 calcium channel blockers were there. So he was taking that. What are this nifedipine and diltiazem he was on. That's what happened in our clinic. So our medical officers are keep on prescribing when blood pressure is high. They do not want to up-titrate medications he is on, and they do not want to see the classes the patient was prescribed. So duplication of the drug class. Constipation may be secondary to calcium channel blockers. The constipation is one of the commonest side effects in elderly, secondary to calcium channel blockers. So now you are prescribing lactulose in spite of patient is on 2 calcium channel blockers. So continuing iron therapy in spite of normal hemoglobin level. He had 1 year ago this problem, and his hemoglobin was 12.8. For an 80-year-old gentleman, 12.8 is a very good value. So why we are continuing ferrous sulfate? Keep on continuing. And so then can up-titrate, we have to think rationally. You can up-titrate Hamipil. He was on 2.5 milligram noctate Hamipil and 2 calcium channel blockers. Why can't we up-titrate Hamipil and this hazardous calcium channel blockers? We can stop. So that is what is called rational thinking in prescribing in elderly. So the next thing is whether he had this psychotic problem 3 years ago, whether he needs to continue this antipsychotic so far. So now still he is on risperidone. So my patient's story doesn't stop here. So then the other thing is, so not only cutting down the drugs, there are some instances where we should prescribe drugs which are indicated if there are no contraindications. There is no discrimination for the age. If he is having chronic stable angina, if there is no contraindication, we should start him a beta blocker. He was not on beta blocker. So case scenario doesn't stop here. Daughter's observation during her visit in after 12 months. The daughter who came from UK noticed that father was slow in his walking and some tremors in his right hand. He was taken to a doctor, and following clinical examination, it was found that he got signs of Parkinson's, and he was prescribed levodopa, carbidopa, quarter tablet TDS. So, so now this man, in spite of having these 10 drugs and 2 brown bag, this over-the-counter drugs, he was given this thing also. What is the possible primary cause for his new symptom? He got some Parkinson's symptoms. He was on risperidone. So why we can't think of it is antipsychotic induced Parkinson's? So that's what we have to think of. So he doesn't have this psychotic problem also at the moment. So can it be antipsychotic induced Parkinson? That we should come into our mind. So story is still continuing. What do you call this inappropriate prescription? That is, if somebody is developing side effect for an existing drug, if you are giving another new drug to cure the side effect of the existing drug, that is what is called prescribing cascade. Now my gentleman is facing the prescribing cascade if you are if you are correct. So case scenario doesn't stop here. So 2 weeks after starting anti-Parkinson's medication, Mr. IM had a fall, secondary to dizziness and imbalance. So fortunately, he did not have a crack. So following the correction of, now we all go through this thing and we rationalize his prescription. Following the correction of his prescription, he left with fever drugs as follows. So only aspirin 75, ramipril we up titrated, tamsulosin 0.4, atorvastatin 20, and bisoprolol 2.5. So we were able to stop some drugs which were having some side effects and adverse events, and duplication was stopped. So then these are the 5 drugs. Now my gentleman is happily coming to the clinic and he is very healthy. So therefore, after going through this case scenario, so we can understand elderly people are having high susceptibility for polypharmacy, drug interactions, adverse drug reactions, prescribing cascade, and not only that, the poor compliance also. When the number of drugs are increasing, the compliance is very poor. I should say our counseling ability is also very low when it comes to elderly. You just prescribe and send them away. And potentially inappropriate prescribing is also one of the susceptible things. So potentially inappropriate prescription is if the prescribed drugs risk is higher than the benefit, and also if there is an overprescribing, excessive doses, duration of medicine, the polypharmacy, all these are overprescribing. That is also inappropriate prescribing. Misprescribing is also an inappropriate prescribing, that is unfavorable choice of medicine, dose and duration. And also underprescribing, that is also inappropriate, not prescribing a clinically indicated medicine like beta blocker in my gentleman, despite patient not having a contraindication. So this table shows major physiological changes and pharmacokinetic effects happening in elderly. Pharmacokinetic process, distribution, metabolism, administration, physiological changes, because when we are getting older, so our body mass, linear muscle mass get reduced. That is what is called sarcopenia, which is replaced by the fatty tissue. So water soluble drugs and fat soluble drugs, their volume of distribution is changed. So we have to be very careful when we are prescribing, especially fat soluble drugs. Their volume of distribution will be high. And also the metabolism wise, the hepatic mass is low, therefore hepatic clearance is low. They have to be very careful when liver metabolized drugs are being prescribed. So excretion wise, as I told you, the functional unit, the nephron, there will be time related loss of nephrons. Therefore renally excreted drugs are getting accumulated when you are prescribing them, especially gentamicin, lithium, digoxin, AC inhibitor like drugs. So we have to be very careful in those situations. So we have to answer 4 questions when we are doing a rational prescribing for elderly. First thing is, does this agent reflect the priorities of the patient? So second thing is, are there any alternatives? That also we have to consider. The third thing is, are the dose, frequency and formulation appropriate? Fourth is, how does this prescription relate to the concurrent medication? If we can answer these 4 questions, you are near to the rational prescription for an elderly. So we have discussed the polypharmacy. Polypharmacy is a geriatric giant, one of the geriatric giants. So polypharmacy is, as we told, so it's a 5 to 10 drugs at a given time. So it is an independently associated with increased adverse drug effects and increased hospital admissions, and hip fracture, decreased physical and cognitive capability. It decreases physical and cognitive capability, and independent risk factor for hip fracture. And increase the possibility of prescribing cascade. We know what happened to our patient, and also problems of adherence is there. So having said that we will move to the stop and start criteria, where when we are rationalizing the prescription for the elderly, there are 2 criteria we have to consider: stop and start criteria. Basically, stop is to stop some drugs in the prescription of elderly. Start is to start some rational drugs to the prescription if there are no contraindication for the individual patient. So stop is shortly says that screening tool of older person's prescription. Start is screening tool to alert doctors to write prescription. So aims of stop and start to prevent what we have discussed so far, the errors we are doing in elderly prescription, to prevent inappropriate prescription, to improve medication appropriateness, prevent adverse drug events, and reducing the drug costs. The contents of stop is like this. It categorizes according to the systems, and cardiovascular, CNS, gastrointestinal likewise. And I have selected some common things in the cardiovascular system. You can see these are the occasions, instances where we have to consider twice when these things are there. Digoxin in impaired renal functions that we have discussed. And once you go through these lists, you can see there are common things that we do. Combining beta blockers and calcium channel blockers. This will lead to symptomatic bradycardia, pathological bradycardia. So calcium channel blockers in constipation. Constipation is one of the common problems in elderly. So if you are prescribing calcium channel blockers, we have to be very careful, and we have to tell the patient you can get the worsening of their symptoms, and duration of warfarin therapy also. Sometimes the DVT and pulmonary embolism, there are very clear-cut guidelines how long that we should give warfarin, but our patients are keep on getting warfarin from the clinics in spite of all these guidelines. So we have to be very careful. And central nervous system, tricyclic antidepressants are very common state available antidepressant. So like amitriptyline and all. So you give enormous amount of tricyclic antidepressants for all these pains and neurological things to the elderly patients. So we have to be very careful of these indication when we are giving tricyclic antidepressants in dementia, glaucoma and things. Those are not indicated. So gastrointestinal system, also especially the proton pump inhibitors, we keep on giving them. So if we are giving more than 8 weeks, we have to be very, very careful. And respiratory system, systemic steroids, instead of inhaled steroids in COPD, those are common errors we do. And nebulized ipratropium, when glaucoma is there, they can have a lot of blurring of vision. When you give ipratropium, without our knowledge, we prescribe them. And musculoskeletal system, NSAIDs are prescribed very frequently. We have to be very careful with heart failure, severe hypertension. They get the worsening of symptoms.
You have 5 more minutes.
So urogenital system, so antimuscarinic drugs we prescribe all the time for their incontinence or whatever their antimuscarinic drugs are prescribed. So we have to be very careful. And endocrine, beta blockers in diabetes with hypoglycemic episode, they will lose the hypoglycemic awareness if we are giving beta blockers. Duplication of drug classes, opiates, NSAIDs, we discuss AC inhibitors, ARB combined in a single prescription. SSRIs are combination of SSRIs are there in their combination. Calcium channel blockers we in our patient also. Then the start criteria. Start criteria is to start the medication if there is no contraindication. So it's a rational way of starting some new drugs. This is also categorized according to the systems. So CVS, the warfarin, we are very reluctant to start warfarin for elderly, but if there is clear indication and no contraindication, if somebody to follow the patient, we can start chronic heart failure, warfarin in chronic heart failure. So aspirin, all these things are, we have to consider starting the medication if there is an indication of your patient. AC inhibitors in chronic heart failure, we hesitate to start those drugs, but we should rationalize it. So central nervous system, the common in occasions where we should start some drugs. And musculoskeletal system, calcium and vitamin D therapy with osteoporosis, those are common occasions. And endocrine system, metformin in diabetes mellitus and metabolic syndrome. So these are the common occasions we should rationalize. So at the latter part of my, we are in the latter part of my presentation, the stepwise approach for prescribing. There are 8 steps when we are when we are having a rational approach for prescribing elderly. So we have to review the current drug therapy, discontinue unnecessary therapies, consider adverse drug effect for any new symptom, consider non-pharmacological approaches, especially in elderly, care in the use of common drugs, reduce the drug dose, simplify the dosing schedule, and prescribe beneficial therapy. So how we review the current drug therapy? So you have to discontinue drugs if the indication is no longer exists, like iron and risperidone in our patient, and substitute with new safer drugs. You can give new safer drug instead of hazardous drugs. So you have in the geriatric medicine, we say start low and go slow. We have to start with very low dose and we should up titrate very slowly. So change the drug doses at correct time, and renal liver adjustment we should do. And when new symptoms appear, consider drug interaction or drug side effect rather than a new symptom, and you have to prevent the prescribing cascade. So discontinue unnecessary therapies, and we have to consider goals of care and indication. We have discussed those things, risk of adverse effects, and if there is any occasion where we have to discontinue unnecessary therapies, we should be brave enough to discontinue, even if it was prescribed by your consultant. So that is what is called de-prescribing the process. That is also we should do when we are rationalizing the prescription. Consider adverse drug effect for any new symptom to prevent prescribing cascade, and consider non-pharmacological approaches like doing physiotherapy and the heat therapy for the osteoarthritis, lifestyle modification in lieu of pharmacotherapy. So these are things we should consider as non-pharmacological approaches. So we have to be very careful when we are using common drugs, especially the NSAIDs and calcium channel blockers like drug. You should simplify the dosing schedule, especially in elderly. The 4 or less than daily. Usually we tend to give morning and evening doses rather than very complicated dosing regimes, and minimize the dosing confusion and poor compliance. That will minimize poor compliance. So you have to prescribe beneficial therapy. Conclusions are these. Consider you are prescribing for frail elderly. Pay attention to pharmacokinetics and pharmacodynamics. Consider new problems as a consequence of a prescribed drug. And you have to consider stop and start criteria when you do a rational prescription. And you should start slow and go slow.
Thank you very much, Lasantha, for your descriptive talk on the topic, very important topic. So it's time to clear your doubts. We have 5 minutes.
Sorry? Stop has 2 P's, yes. You mean start? Stop and start.
We are very curious because I know it's not a mistake.
Yeah, it's not a mistake.
Yes, so what is it?
Yeah.
There you go.
Older person's prescription, PEP. Screening tool for older person's prescription. Sorry, sir? Start. That is stop. Start is starting screening tool to alert doctors a right prescription. STAR.
Study done, I suppose, Madam, if you can enlighten a little bit about that.
Find out how the prescriptions are in elderly people in Sri Lanka, and found that there were some limitations when we use Stop Start because it was not developed for Sri Lanka. So obviously some of the medicines that are described in the Stop Start were not in our formularies and available in the country, and the situations were different. So we had a Delphi consensus where we have developed the Stop Start criteria for Sri Lanka with approval from the original authors of this. The Delphi consensus and our criteria have been also published. We have done the validation part and the data is being analyzed. So we will know how it compares with the original Stop Start and whether we could use a Stop Start. Just to add to that, Stop Start is not something you can use while you're prescribing because it's a huge document unless you take sections. And then again, you might miss because if you just take the cardiovascular one, then some of the other important ones will be missed unless the physician is aware that they can test. So one thing we could do if we have a very good clinical pharmacy service is use that as well, and at the time of dispensing the medicines maybe they could check that and highlight it to the prescriber that this interaction is there. So it's not really a practical thing to do while you're prescribing, but something to use if you think your patient has a problem and you need to really go through that. But it's a very good document. It's been validated to Europe. It was developed in Europe, to North America, and we will be validating. We have collected the data and it will be analyzed for Sri Lanka as well. So it will be available soon. Yes, there are many. Beers is one, then MA is there, medicines appropriation index or something like that, appropriate index. There are many criteria. Beers was slightly different when we started using Stop Start, but beers have also now migrated to something similar to Stop Start where you go by systems. So it's much more easier.
Beers is going to a system.
Now, yes, the new one has done that, yes.
Yes, then we'll wind up the session. Any questions?
You mentioned that after 2 months, you have to be very careful about prescribing PPIs. So we see most of our patients are on PPIs for a duration longer than that. So any specific reason why you mentioned it?
Yeah, the one thing that we are commonly that we are alkalizing the gastric acidity. So especially in elderly, they do not have much acidity in their stomach. So if we are going to continue more than 8 weeks, we have to rationalize why we are continuing. Sometimes it might be a short that symptom may need short term of PPIs. So if we are keep on giving PPIs without having these indications, so that we have to rationalize at the point of 8 weeks. pharmacists are they advised not to prescribe, not to deliver the NSAIDs beyond the prescribed duration. So if it's an error of pharmacists if they are going to give this more than the time which is prescribed, which is a that's yes. But the risk is the same. And not only that, there are 2-3 NSAIDs in single prescription.
Right. So because of the time limits, we'll stop this presentation, and I would like to cordially invite my co-chair, Professor Chandani, to hand over the token of appreciation to Dr. Lasantha.